Good afternoon, everyone. In the next few minutes, I would like to introduce you the topic of my PhD thesis, optimization of acute pancreatitis management. I am a gastroenterology resident in the military hospital in Bucharest, and this year I am part of the translational medicine program with a scholarship offered by MOL Group, and by this way I want to thank them for giving me this opportunity. My supervisors this year are Dr. Balinteros and Dr. Hegi Peter. And my vision regarding acute pancreatitis is that we can decrease mortality rates and complications, and my mission is to fill the gaps in the guideline. My specific goals are to answer two clinical questions. The first one is regarding efficacy and safety of prophylactic anticoagulant treatment in acute pancreatitis. At the basis of this project was the fact that acute pancreatitis is an inflammatory disease, and as a consequence it is associated with vascular injury, activation of coagulation, and increased leukocyte rolling. There are some studies that have shown that anticoagulants have the ability to reduce the inflammation and accelerate the recovery in acute pancreatitis because in addition to their well-known anticoagulant effect, they have the ability to regulate inflammation and decrease the level of cytokines level and other mediator of inflammation. For this, we use the PICO framework, and our hypothesis is that administration of prophylactic anticoagulant treatment is safe and improves the outcomes in acute pancreatitis. We performed the search on 3 databases. On October 14, 2021, our search key had 2 main concepts. And our search retrieved a total of almost 8,000 articles, from which we included only 7 in the meta-analysis and 9 in the systematic review. Now I will show you some results. I will start with mortality. That is our primary outcome and the hardest one. For this analysis, we included patients with moderately severe and severe cases of acute pancreatitis. As you can see, all studies report similar results. Respectively, there is a benefit from additional anticoagulant treatment in acute pancreatitis. Although we have similar results, there is a moderate heterogeneity of 57%, which is brought, we performed the leave one out analysis, and the outlier is the study of Kroner, which is a propensity matched case control study that included older population with a mean age of 65 in comparison with the mean age of the other studies that was almost 49. Moreover, for this study, we don't know the distribution of the severity for the population sample. Our analysis revealed that by adding anticoagulant treatment, the odds for dying in the anticoagulant group is 43% in comparison with the control. Clinically, this means that mortality in the anticoagulant group is less than half in the control group. In addition to this, we performed the subgroup analysis only for RCTs that bring the highest level of evidence and can better evaluate the magnitude of the effects of anticoagulants in acute pancreatitis. And they show us that by adding anticoagulants, we can lead to a 76% decrease in mortality rates. And our results are significant. Highly related to mortality is multiple organ failure, which is common in severe pancreatitis. We also perform subgroup for RCTs, and in RCT subgroup we can show they have similar results in favor of anticoagulant group, and they have low heterogeneity in comparison with the overall. Again, the heterogeneity is brought by the study of Kroner with the reasons I already mentioned. And our results show that the incidence of multiple organ failure is decreased with almost 67% by adding anticoagulant treatment. Another outcome we were able to analyze was the need of endoscopic or surgery intervention. Most of the articles have similar results, except the study of Chaklin from 2019, that is a conference abstract, so we don't have so many details for this population. We only know that they included severe patients, but we don't know the distribution of the other comorbidities, neither the etiology for the cases of acute pancreatitis. We can see that by adding anticoagulant treatment, the need for intervention is reduced by half. Furthermore, we were able to perform another subgroup analysis for the need for endoscopic or surgery intervention regarding severity. And I should mention that we included only few studies for this outcome. And we can see that for severe cases, we can decrease the need for further intervention with almost 30%. On the other hand, for the moderately severe pancreatitis, if we add anticoagulants, we can decrease the need for further intervention with almost 70%. So it is almost double. And I would like to draw your attention because by adding anticoagulant treatment earlier in the course of the disease, patients may benefit more. Regarding the length of hospital stay, the articles provide the mean and standard deviation and the measure of the effect as the mean difference. And our analysis revealed that the length of hospital stay can be shorter with around 5 days by adding anticoagulant treatment. So the strength of our study is that we have an increased level of evidence because we were able to perform subgroups for RCTs in every outcome. And we have a total number of patients, more than 200 in every subgroup. We have low heterogeneity when pooling only RCTs, and we used a robust methodology. The main limitations are that we have a low number of studies included in moderately severe subgroups. There are few studies that report the safety outcomes, especially the bleeding and the thrombosis, and we couldn't perform the publication bias due to the fact that we have less than 10 studies. Moreover, we have a high risk of bias in some cases, which is mainly due to the bias in the selection of the reported results. To sum up, anticoagulants reduce severity, mortality rate, systemic complications rate, the need for further intervention, and the length of hospital stay. So we should add this anticoagulant treatment and because this is a benefit for patients with moderately severe and severe pancreatitis, and we should further evaluate the benefits of anticoagulant treatment in the mild pancreatitis, and we should report the safety outcomes, especially the bleeding. Now let's move forward to my second project entitled Safety of Early versus Late Endoscopic Percutaneous Interventions in Infected Necrotizing Pancreatitis. Infected necrosis occurs in 40–70% of the cases with necrotizing pancreatitis. But since the introduction of the step-up approach, there is a debate in the literature regarding the optimal timing of the drainage. On one hand, we have the European guidelines that recommend delayed intervention after 4 weeks, and on the other hand, we have the American guidelines that recommend we should make the percutaneous intervention in less than 2 weeks. For this, we use as well the PICO framework. Our hypothesis is that postponed intervention are safer than early interventions in infected necrotizing pancreatitis. We performed the search on 5 databases, and the search key has 3 main concepts. As a summary, we plan to submit our first article at the end of the month, and the next one then in June 2022. I would like to thank you for your attention and to end my presentation with a quote of Vincent van Gogh that great things are done by a series of small things brought together. If there are any questions.
Congratulations. Was it a preventive or an ongoing anticoagulation therapy in the study you analyzed?
It's prophylactic, it's preventive.
So it was stopped at the onset of acute pancreatitis?
Yeah, it started at the onset of acute pancreatitis. The first day the patients were diagnosed, they received anticoagulants.
So it was an ongoing anticoagulant therapy. I see. Okay. Thank you.
Is there any information on the dosing? Because I've seen that there were prophylactic and therapeutic doses applied in the studies.
we also performed subgroups regarding the dosage, but I couldn't add this because of the timing. I was late. We have two subgroups, the prophylactic dosage and the therapeutical ones, and there is no big difference between the two of them.
Mm-hmm.
So from this we can conclude that we can give all of them prophylactic dose.
Thank you, Cristina, for the presentation. Can we go to one of your last slides, the forest plot of the first project, please? Yes, so there seems to be the first article, Lu 2009. Could you explain why that's so different, the outcome?
Regarding the length of hospitals, they have a bit, it's a big difference between them. Well, I can say that, for instance, Lu is an RCT that has only severe patients in comparison with, I don't know, Kroner or Jiao that might have moderately severe or mild cases. So if patients have severe pancreatitis, they might stay a little bit longer in hospital.
At least I don't understand everything, and I tried to ask it my co-chair, but he didn't give me any hint. So was it in the dose? So sometimes it was a prophylactic one, sometimes yes, it was a therapeutic one. But what was the indication of the anticoagulant therapy?
To see...
because you said that the therapy, the anticoagulant therapy, was started at the onset or at the admission of patients with acute pancreatitis. Am I right?
Yes.
So what was the indication of especially the therapeutic anticoagulant therapy?
Well, they want to prove the effect of anticoagulants in acute pancreatitis. And there are some studies from the same hospital, respectively, for the dose that for the first patients received prophylactic and then the others received therapeutical, maybe in order to see the differences.
Okay, so that was the design of the study to analyze the effect of therapeutic anticoagulation on the outcome of acute pancreatitis.
Yes.
And the anticoagulation was not given because any thrombotic event or any...
No, we excluded these patients that had thrombotic and thrombosis.